And I'd like to talk to you today about how we did some of that, but also in respect to some of the reflections in terms of how well or otherwise that actually worked. So just to give you some context in terms of Ireland, it's a little bit different from Sweden in the sense of COVID for us, as you can see, we've had kind of 4 separate waves. A very significant wave after last Christmas on the foot of reopening, and obviously a lot of socialization after Christmas, which resulted in a number of cases and consequent deaths. And we've also had a kind of very consistent sort of 4th wave since October. Again, we had a reopening in on October 22nd, and we've had a kind of climbing of our cases ever since. So very much seeing similar sort of situations in other European countries as we've had here in Ireland. Interestingly, there's been a lot of discussion in Ireland in respect of the Swedish approach, one of personal responsibility and not so much about lockdowns. We have had some of the most, I suppose, strict public health restrictions in all of Europe, and we've had long periods of lockdown for our population, and that has been very burdensome for the general population in lots of different ways. So a lot of discussion, as Elena has said, about the merits and otherwise of that and the justification of it. In terms of our vaccination, we're one of the most vaccinated countries in Europe. About 91 to 92% of our eligible population, and that's 12 years and up, although we've just decided to offer vaccination to those 5 to 12. But in any case, we have 92% of our population fully vaccinated. So that's to give you a kind of sense. You can't read this, but it's to give you an idea of just how comprehensive our framework was, and in terms of just how many public health restrictions could be in place at any given time. What you'll see there is level 5, a lot of red, and red basically means that most things were shut down. We're not allowed to open, only essential shops, for example. And at one point, people weren't, for long periods of time, over months, people weren't allowed to move more than 5 kilometres outside of their home. So just some kind of, I suppose, very much to this morning's discussion. And I think this is Torbjörn's challenge to us, in a sense, about whether, questions of utility really did we end up coming to similar sort of approaches. And I think it's really interesting that public health interventions have already really traditionally kind of been rooted in this utilitarian approach. And very much when we went back to look at how we would do our ethical framework for the current pandemic, we were looking back to previous pandemics, which were very rooted in that idea of utility. And what you did see in that interval, I think in that 10-year interval, when we came to the current pandemic, was there had been a shift, I think, already from utility to equity. And that was very much this idea of principles of distributive justice, etc. And also, I think, as Laura talked about, the kind of influence of human rights frameworks, allocation of resources being linked to human dignity, as we've discussed a lot today. So there was already that shift, I think, from utility to equity. And I think the WHO framework for the allocation and prioritization for COVID-19 vaccinations very much was talking about that balance between utility and equity. I think it is really interesting if you look at some of the studies that have been done around analysing all of the various guidelines that have been used by countries. And this particular study is of European guidelines. That the principle of equity really has become quite central. But it's important to note that equity is considered in various different ways here, and the approaches can be quite different. So there's this egalitarian idea of using equity and non-discrimination, as we've talked about. But then there's a more utilitarian approach, which is about equity and best use of resources, tempered, I suppose, as equity as a side constraint. And then I think most interestingly, there's this idea of equity and ethics of care. And I think Elena made reference to this as well, and this kind of case-by-case approach, individual needs and will and preferences of various patients. And I think that is interesting because it really does mark quite a different shift. And so I wonder if for the next pandemic, which hopefully I will be retired for, will we have moved from utility to equity to something else which looks like care ethics? And if that's the case, how does that actually work in a public health ethics prism? And I think that's going to be very interesting, maybe something we could discuss. So again, obviously, for everybody in this room, it's very clear why one would need an ethics framework. Priority setting had really tangible consequences for people's health, and it required us to think about values and making the kind of choices to make explicit the values that we were using to make these kind of choices around resource allocation. So we here in Ireland published an ethical framework for decision making, recognising very much, I think, as well, that there were going to be policymakers and clinical decision makers who needed to be supported in how they would make those decisions. And so we had to give some sort of basis for them to make the decisions upon. We don't have a legal framework as you do in the sense in Sweden of being very clear around that. So we felt that this was very important to provide our decision makers with. So this is what it looked like. We set out a number of ethical principles and then a number of procedural values to guide the resource allocation, feeling very clear that we had set out, what we meant by minimizing harm, that harm wasn't just harm to life, but there were other harms that needed to be taken into consideration, and trying to elaborate what each of those principles meant in terms of resource allocation. And then equally important, it's not just, somebody said, I think it was Christoph said earlier, it's not just about how the pie gets cut up, but also, again, not even the shape of the pie, but who, how we come to that division of the pie. And the importance, I think, of procedural values. And I'll come back to that in terms of the importance of procedural values in trying to promote trustworthiness. So I'm going to take a couple of examples for us, mainly around PPE, provision of PPE, provision of critical care or access to critical care, and also vaccination. So PPE, this will have been a common experience for everybody in Europe, but we in Ireland had shortages of PPE, which meant that we had to decide who would get access to personal protective equipment. And recognising that even with rational and appropriate use of PPE, it was in short supply. You will see our national airline, Aer Lingus, there's a picture of that on our national news. We actually had pictures of aeroplanes landing from China with consignments of PPE that our government had managed to secure through all sorts of channels. That was actually shown on our 6 and 9 o'clock news to herald, isn't it wonderful we're getting all of this PPE into the country, because such was the concern for healthcare workers that they simply didn't have access to adequate PPE. But not so much, I'm not going to talk about the issue of how PPE was being distributed, although there are questions around, the distribution of PPE was very clear in acute hospital situations. But I think there's also the question of long-term residential care, community hospitals, to people in their houses, when they had, for example, support staff, medical care coming in to support them on a daily basis, all those questions. But another question arose for us, which was, what is the duty of care of healthcare workers to actually discharge their duty of care in the absence of adequate PPE? So we ended up having to give a certain amount of guidance in respect of that, and recognizing that, in fact, there was a duty of care. It did persist in a pandemic, but that there was a distinction to be made about the kind of risks that we considered it would be appropriate for our healthcare staff to run. not least because we needed them to be fit and healthy to actually, in terms of the sustainability of the healthcare system. So it was very much that an assessment of this relative risk benefit had to be taken on a case-by-case basis, and we tried to give people a number of criteria which are on the slide there, in terms of how they might consider their risk and how they might be able to then determine what their obligation or duty of care to the patient might be. So that's an interesting one in terms of, I suppose, an issue that arose as a result of PPE shortages. So something we've talked about a lot today in terms of ICU capacity. And I mean, in the very early days, we were seeing pictures from Bergamo in Italy and other places where, ICU capacity was running out. And it was very much felt that we needed to give some guidance to the system in respect of what would happen. So it's interesting in terms of our guidance. It's a bit of a mix. It's very much along the lines of trying to balance utility with equity. And I suppose the starting point for us was that that everybody, every life matters and everybody would receive care. Now, the nature of that care might be different, and I'll come to that, but that everybody would receive care. Again, we recognise that every patient was unique, and clinical judgments will and should ultimately be made on a case-by-case basis. And that comes, I think, to a very interesting point that Elena made as well, which is actually, if you look at patients, rarely in the literature we talk about, and this is this kind of theory and practice, that if you have two patients who are exactly the same, how does one make a distinction? That rarely, in fact, happens. There are usually distinguishing factors. And I think that goes to the importance of actually looking at a patient, the individual patient, within the context in which you find them. However, there is this kind of duty to limit resources prudently and fairly to minimise the loss of life and suffering. And here we come to the utilitarian calculus, to use that for the maximum benefit possible for the individuals served by those interventions. So that's, again, where we did use utility as a guiding principle. So I think another important point for us, and I think gets missed in this discussion sometimes around access to ICU, was that it was really, we felt essential that clinicians would discuss the possible risks and benefits associated with intensive care. And that sometimes I think there was a conflation of scarcity with value. Now, that happened, I think, in relation to access to ICU, but also in some other discussions. But it was most striking here that simply because there was a discussion in the public domain that it might be necessary to ration ICU care, then it became, I need to have ICU care, therefore. And in fact, it wasn't going to be appropriate for everybody. And that's true in everyday scenarios, quite outside of a pandemic. But that seemed to be a much more difficult discussion to have with people. So we felt it was really important that the patient's will and preference would play some role in that question. So very much, again, no single factor. For example, a person's age should be taken in isolation as a determining factor, and decisions couldn't be made arbitrarily or in such a way to result in unfair discrimination. So we also felt it was very important that in terms of fairness, that you would apply a consistent approach to considering the predictors of outcomes for all ICU admissions. And this included patients with COVID-19 and patients without COVID-19. And that's an issue I want to come back to as well, because we were very clear that the capacity, we had a limited amount of capacity, but that we were constantly talking about patients with COVID, but that needed to be balanced in respect of patients who would need access to ICU for non-COVID related reasons. And that proved much more challenging, in fact. So, rationing critical care, what were the kind of things that happened and the lessons we learned? It was really interesting that even though the guidelines had made it really clear that no single factor, and then we had put example age, and that was largely because that there were a number of discussions which were emanating out of other European countries where, for example, there was some suggestion that an age ceiling would be placed in respect of access to critical care. And so we had simply said, so we were very clear, no single factor, for example, age, But actually, this caused a good deal of distress amongst some of those in our disability community, who said, well, you don't mention disability. Is disability going to be a prohibiting factor, if you like? And we kind of were very taken aback by that, because we didn't understand when we had made it quite clear that it shouldn't be a single factor, and disability being a single factor. But I think it spoke to something which was quite deep-seated, which was a real fear on behalf of some members of our society that they would simply be not treated as an individual, but rather as a member of a group, or, with a particular underlying condition that would immediately exclude them from critical care. So we had to actually publish a supplementary set of guidance, which made very clear, and also, I suppose, went into the fact that even though, and we've talked about this morning, so even though your underlying condition or your disability, or indeed your age, may contribute to frailty, may contribute to your ability to recover or to benefit from ICU care, that isn't the only factor that needs to be taken into account. I think the other thing that we learned, and I think is really important, is the importance of not using crisis standards of care when you're at contingency capacity. So I think there was a certain amount, especially in the early days, where people were so worried about becoming overwhelmed that, thankfully this didn't become the case in Ireland. But I think there was that feeling in the international literature that people started to think about their obligations in terms of trying to make decisions which were really more around crisis standards of care, rather than the contingency situation in which they found themselves at that moment. We in Ireland, and I think that's probably replicated certainly in other countries that I've spoken to, there was a concern on the part of our clinicians around liability. They didn't want to be in a position of making these kind of decisions. So even though there was quite detailed advice, both at the government level and indeed from clinical organisations, there was, real concern about this idea of having to make these kind of choices. And so we had to give a certain amount of support and reassurance to our clinicians that there was a duty to act reasonably, not perfectly, and people can't be held to standards, so in hindsight, where you would have thought, well, this would have been a better way to do it. And I think what was really interesting is, though, even we provided quite detailed guidance, there was a discussion at some hospital levels that actually they wanted to use scoring systems. So they were very keen. The scoring systems were easy to implement. They were clear. They were considered to be fair. Whereas we were talking about a much more nuanced approach, which was talking about taking into account lots of factors, balancing various principles, etc. And I think that really made clear to us basically the challenges of implementation at the clinical level. So when we talk in abstract terms about allocation of scarce resources, I think we really have to think about how that practically can be rolled out on the ground and at in terms of clinical decision making. And that caused us to have to, so we were very keen to say, no, we don't think the idea of scores is the way to allocate resources. But then we had to give additional support to say, here's how we think you should go about, both in terms of looking at the principles, actually coming to a decision, and how you actually apply the procedural values to making that decision. And I think that was at least helpful on the ground advice for people who were struggling with ethical principles in the abstract of how they might actually be applied in concrete situations. And I think that's something as ethicists we need to think about and perhaps do better with. In terms of vaccine allocation in Ireland, we, like other countries, of course, had to do a prioritization. In the beginning, resources were very scarce. Because we had quite restrictive lockdowns and people's liberties had been restricted for long periods of time, there was a real case of, and I mean, this has subsequently obviously been interesting in terms of vaccines, but there was I suppose, a feeling that vaccines were the way out of the pandemic, and that if we could only roll out vaccines to the population, that we could all return to normal and things would go back to normal and we could escape this. And so I think there was a real sense of, should I say, pent-up demand in Ireland in respect of vaccines. We in Ireland like to talk about the weather a lot, but in fact, for a period of time around December or January of this year, the only thing Irish people could talk about was when would they get their vaccine? Had you got your vaccine? Had you been contacted to get your vaccine? So this was the dominant discourse in Ireland at the time. So it was very much about trying to decide, and we in Ireland did something similar to what they had done in Germany. So we had ethics alongside of our national immunisation group worked together to put together a prioritization, which was informed by this multi-value allocation framework, which again had a number of principles. You can see them there: moral equality, minimizing harm, fairness and reciprocity. Interestingly enough, to the earlier discussion, we had prioritized healthcare workers for vaccines, but not actually for ICU care, because we saw them for different reasons there. And then the procedural values also. So that actually worked really well. And the vast majority of Irish people, so we, as many other countries, prioritised those we considered to be at most risk. And so that was older persons and healthcare workers, for example. Most people were very accepting of that. And I think it was because they could, the rationale, the scientific rationale, but also the ethical basis for doing that was explained quite extensively. And people seemed to really respond to that. So I think the role of solidarity was very strong in the vaccine allocation here at our national level, because people were very accepting of the fact that those more at risk would be first in line. As I say, I think it was really important to demonstrate the ethical legitimacy of the overall decision making. And I think that was buttressed very much by explaining the clinical and scientific reasoning behind why the prioritization was done in the way it was. Now, we, I'm sure, like other countries, had certain relatively isolated cases of people jumping the queue. And that was attracted a lot of very negative, understandably so, very negative attention from the general population, many of whom were waiting very patiently to receive their vaccine. And I think that really does speak to the importance of fairness and justice considerations, because solidarity was, we had a very cohesive approach, I think, to both the public health restrictions and vaccine allocation. But that starts to break down if people feel that there is not fairness in how things are being done and how the resources are being allocated. So I think some of the things that I would point to in terms of really the importance of transparency and communication. And there are some challenges, I think, that we really need to think about here. I think acknowledging uncertainty. So it's very easy to say we should be transparent with people when we communicate to them. And even in terms of ICU access and some of the things we've talked about at this meeting, one thing that I've thought a lot about is when we say, oh, the utility of it for a particular person, or whether they, the quality of life or the length of life or whatever, when you're dealing with a completely novel virus as we were here, we didn't actually know a lot of that. So saying that, who would recover or whatever, we actually in the beginning didn't know the characteristics, who was most likely to recover, to do well or not to do well. That's something that gradually emerged. So I suppose the challenge of acknowledging uncertainty while maintaining the confidence of the general population. You don't want those who are tasked with making the decisions coming out and saying to people, we don't really know. We're kind of just, doing this on a day-to-day basis. That obviously undermines confidence, but we still need to acknowledge uncertainty. In our vaccination program, it was interesting. in terms of our prioritization, it changed several times during as the vaccination campaign went on. So in the beginning, we had vaccinated by essential workers, and we had used evidence to actually help us do that. So transport workers, healthcare workers, shop workers, etc. But as it became increasingly clear that age was the greatest risk, we switched to an age-based approach. And then we had to go out and explain to those transport workers why they were no longer prioritized. So, if you were a 30-year-old transport worker, you had gone right down to the end of the list, whereas you had been 4 or 5 in the list. And so that was very important to explain to people, this isn't about us changing up the list and making U-turns, which was how it was portrayed to a certain extent in the press. But it was because new evidence had emerged and we were being responsive to that evidence. Again,
you have 30 seconds.
Yeah, so I'm coming to the end here. Inclusive decision making, I think that's really important. So when we're talking about values and ethics, how do we actually ensure inclusive decision making during a crisis? And the challenges of that kind of consultation during a crisis, and maybe the importance of conferences like this and seminars like this, so that we don't end up doing it during a crisis. So we adequately prepare, and that ethics is absolutely central to that preparation. And then my final piece, I think what's interesting about what COVID has done is that we didn't talk a lot about resource allocation. I think, at least in Ireland, even though we have a very resource-constrained healthcare system, like many other countries. But I think that this has perhaps, because people were shocked with the idea of talking about rationing care. But of course, we do that in healthcare systems all the time. So I wonder if this hasn't opened the door to those discussions, to have perhaps a more inclusive, open debate around that. And my final point, Niels Erik, if I might, I think something we haven't touched on today, and I think is going to become increasingly important, is we've talked about allocation of resources in the context of COVID and to COVID patients. But there is that whole other issue of allocation and making sure that we ensure that we have equitable allocation to everybody else in our healthcare system who isn't suffering from COVID, but who has certainly, I suppose, come to the end of the queue in terms of elective surgeries, misdiagnoses, etc. And I think that's something we really need to think about. Thank you so much.
Okay. Thank you very much.